Hey everybody, Bob Gibson from Rosk. We're here to have a quick chat on ABGs versus VBGs, and this includes a plea to stop doing so many damn ABGs, please. Obviously, if your patient has an arterial line, this is a moot point. Otherwise, a VBG may be the best option for a large subset of our ED and ICU patients. We all know that VBGs are less painful and associated with less procedural risk, whereas ABGs are more painful, they're more invasive, and they're associated with greater risk, including bleeding, hematoma, thrombosis, arterial aneurysm, and nerve injury. Additionally, it takes skilled staff to perform ABGs. Let's take a peek at differences in ABG, VBG, and central VBGs. The differences in the pH and the bicarbonate, as well as the base deficit and base excess between ABGs and VBGs lack any clinical significance. These tiny variations mean very little, if anything at all, when you're managing a patient at bedside. There's good correlation, like I said, between the base deficit and the base excess, and there's also good correlation in bicarbonate. However, remember, if you had a choice to use a bicarbonate result from a blood gas versus a chemistry that were drawn at the same time, you should use that chemistry result. And this is a true measure of bicarbonate, where a blood gas is driving the bicarbonate value by using the Henderson-Hasselbalch equation. To provide some clarity to that, it's plugging in the pH and PCO2 into a formula, then spitting out a calculated bicarbonate level. Now, what about PCO2? Well, at relatively normal levels of CO2, there isn't that much variation, but there's more to talk about there. First, there's some very smart folks out there that are trying to validate estimated venous PCO2 and extrapolating that to a comparable arterial PCO2. And that sounds great, but it's in its infancy, and there's logistical issues involving complicated formulas. And in addition, as soon as I add supplemental oxygen to that patient's treatment, it worsens the accuracy of these models. With that said, two situations to consider in ABG in regards to PCO2 would be shock and abnormally high PCO2 levels. First up is shock. We know that shock states cause large differences in venous and arterial PCO2. In fact, some of us use this knowledge to our advantage when diagnosing shock by using the venous to arterial CO2 difference calculation. Next would be hypercapnia. So despite those cool up-and-coming estimated venous CO2 to arterial PCO2 models, I would still suggest considering ABG if your venous PCO2 is greater than 45 and you care about it. In other studies, venous PCO2s greater than 45 had shown poor correlation to arterial PCO2s. So what do I mean by caring about it? Well, if your venous PCO2 is, say, 55 and your pH is fine, that might not be a case that you feel you need to get an ABG. What's pretty cool about all this is if that your venous PCO2 is less than 45, you have a negative predictive value of 100%, meaning in the absence of shock, if your venous PCO2 is less than 45, so is your arterial PCO2, and you can bet your paycheck on it. Now, what about PO2? Well, you got me there. There's been some folks that have tried comparing central venous blood gases to arterial PO2 models, but there's just too many moving parts for them to be accurate. But in the absence of ABG, you can use your pulse oximeter. Just remember the limitations of pulse ox like severe anemia, vasoconstriction/poor perfusion, artificial nails, and dark skin tones. However, if you need clarification or suspect discrepancy, you can then investigate an ABG. So when do I choose between an ABG and a VBG? Well, first let's start with the ABG. If I have a patient that's in shock and I need to have a precise PCO2, then I consider an ABG. Or maybe I have a definitive need to understand an oxygenation parameter that a pulse ox is just not cutting it. Maybe I need to see that PaO2, the SaO2, calculate a PF ratio or an adult oxygen index, or maybe I want to take a look at an AA gradient, then an ABG would be indicated. I will point out that some newer recommendations are suggesting using an SpO2 to FiO2 ratio in place of a PF ratio. However, at any time clarification is needed or there's a discrepancy that's suspected, we should then reach for an ABG. And lastly, if my venous PCO2 is greater than 45 and it's applicable to the clinical problem, then maybe I should consider an ABG as well. As far as VBGs, I use it for everything else. It's a great diagnostic tool for evaluation of an acid-base state. We love a good VBG for DKA. It can also be used as a great screening tool for hypercapnia. And there you have it. Stop doing unnecessary ABGs. Do yourself and your patient a favor by reaching for that VBG first.